Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, answering your questions about quality programs and the transition to value-based care. I'm Brigid Whitney-Gallagher, Manager of Client Services at Mingle Health. And with me here today is Dr. Dan Mingle, family physician, founder, and CEO of Mingle Health. Dr. Mingle today will be helping us understand the Promoting Interoperability category as it applies to Medicare's alternative payment models. Hi, Dr. Mingle.
Good morning, Brigid, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
So before we jump into PI for ACOs, can you just do a quick refresher on the Promoting Interoperability category?
Great question, Brigid. Let's just say it's all about the use of certified EHR technology, or CERT. PI is one of 4 MIPS performance categories. A PI score, that is a Promoting Interoperability score, typically contributes 25% of the final MIPS score, except in cases of reweighting. Practices and providers can be eligible for an exception for any one or multiple of the performance categories. Now, exception means that you get forgiveness for not reporting that category. The weight that category carries into the MIPS score gets redistributed to the remaining MIPS categories that the submitter is responsible for. So PI can go to 0 if a provider or practice has an exception for PI, or PI can be increased if one or two of the other categories have exceptions. So the score that would go to those for the total final MIPS score would be redistributed to PI. Now, there are four objectives captured in PI measures, and there's an overlay of required infrastructure attestations, almost a fifth objective, if you will. So the required infrastructure attestations to get a PI score every year, you have to declare that there are no actions taken to limit or restrict interoperability of CERT, and that you've made an annual review of the High Priority Practices Safer Guide published by the ONC. And you make an ONC direct review attestation that you're available for ONC to directly review issues in your CERT, and that you've done an annual security risk analysis. So those are the baseline infrastructure attestations, and they're constructed to the right answer is yes for each of those. And then there's 4 measure-based PI reporting categories. The first is e-prescribing. The second is health information exchange, essentially that goes with patients in the case of sending or accepting a referral. There's provider to patient exchange of data, and there's exchange of data with public health or clinical data registry in your region. And there's a variety of ways in each of those categories to meet the category objectives, and there's also a variety of exceptions to each of those categories, and as I said, options to meet the requirements. So that you can get that data directly from Medicare or in other. We won't go into great detail, the deeper detail on that in this setting.
I also just want to call out, in previous years, practices have been able to attest no to some of those required infrastructure attestations. In 2024, could a practice still earn points if they attest no?
Great question. You're, I think, referring to specifically the Safer Guide question. And for the first year or two that Safer Guides was in this list, just being aware of them, just saying yes or no was fine to meet that attestation. Beginning with the 2024 submission year or performance year, that answer has to be yes, that you read it.
Great, thank you. So I think we understand a little bit of the PI category. How does that apply for ACOs? What are the ACO requirements? Do they have any? And what do those look like?
Oh, great question, Bridget. Important to this discussion is two sets of two. First, it's current state versus future state because there's a change in the works. And second, it's different if you're a MIPS APM versus an advanced APM. The requirements are a little different. So let's start today. That is prior to the 2025 performance year. If you're a MIPS APM, meaning that you're going to get you're in an APM, but it's not a loss, gain and loss APM. It's not two-sided. You'll be getting a MIPS score and potentially earning a MIPS adjustment of some level. The MIPS PI category applies fully to anyone in a MIPS APM. Now, for all APMs, MIPS or otherwise, routine reweighting of the cost category is in effect. And in that routine reweighting, PI is worth 30% of the MIPS score for MIPS APMs compared to 25, which it's usually applicable to a routine, to the garden variety or what we call traditional MIPS participant. And there's a contractual requirement that at least 50% of participants in MIPS APMs are using CERT, and at least 75% of advanced APM participants are using CERT. Now, if you've got a PI obligation in an APM, you can meet that as an individual, that is an individual TIN and PI, meaning, of course, as we've covered before, an NPI's participation in multiple TINs gives it an obligation. They're an individual at each of those TIN levels. So you can submit as an individual TIN NPI. You can submit as a group, that is all the NPIs in one TIN submit together, or you can submit PI as an APM. And that's applicable to the 2024 performance year and beyond.
Dan, let me ask you. You stated there's a contractual requirement that for MIPS APMs, 50% of participants use CERT, and for advanced APMs, it's 75% of participants. Does that mean 75 or 50% of the NPIs that are part of the APM, or is that another designation?
No, that you're absolutely right. It's 50% or 75% of the NPIs participating in the APM are using CERT.
What does this look like for the future moving forward?
Well, great question. There's a new rule that was introduced in the final rule for 2024, which changes it as of the 2025 performance year. So starting with the 2025 performance year, everyone in an APM, whether a MIPS APM or advanced APM, needs to use certified electronic health record technology, that is CERT. And everyone, whether a MIPS or advanced APM, needs to submit a MIPS PI, make a MIPS PI submission. Now, both of those share the MIPS exceptions to PI. So the usual exceptions apply to both using CERT for an APM and submitting PI from within that APM. These exceptions apply at the individual or group level, except for the small practice designation, which if all the practices in an APM entity are small practices, the APM entity gets that small practice designation. But that's the only exception that applies to the APM level, and APMs are not allowed to apply for specialty hardship exceptions. But the individuals and groups participating in the APM can apply for exceptions and be individually or at the group level accepted from the need to use CERT or to submit a MIPS PI submission.
So in 2025, or in program year 25, when we're reporting for 2025 data, every provider, every NPI will need to use CERT and need to submit PI unless they have some other exemption. Is that right?
That's correct. So Medicare will, as part of their evaluation of the annual scoring and performance, they'll be looking for a matchup between the participants in the APM, and participants are followed quarterly, and snapshotted quarterly. They're going to be looking for a matchup between those and an applicable PI submission. And that, I think, is likely to be their primary means of checking for compliance with the 100% use requirement. Although they also have the option, because the contract exists, they'll have the option to audit the participating providers to make sure everyone's, as they said, as they're claiming, using CERT.
Gotcha. So for 25, everyone has to use CERT and report PI unless there are some exclusions. So let's talk about those exclusions. What are they? How do they work? How would a practice or provider or APM get them?
This is the same across all PI and MIPS in the QPP, whether it's MIPS or APM, starting in 2025. Clinical social workers are still, for the last year or two, the only credential that gets automatically reweighted. So clinical social workers don't have a PI obligation. Ambulatory surgical center-based providers or practices likewise don't have a PI obligation. Hospital-based providers or practices don't have a PI obligation. And small practices, that is practices with 15 or fewer clinicians in the practice TIN, the tax ID number, have no PI obligation, and those are automatically set. So you can check the QPP website to see if you as an NPI, if your practice, you as a group practice, have been granted any of these exceptions. Now, there's also an annual application available for exceptions, and those are available. Medicare gives 4 categories in which they grant exceptions typically. One is if the EHR technology that you've been using has been recently decertified, you can apply for an exception. If you can't use CERT because your practice site has insufficient internet connectivity to make it usable. If you have lack of control over the availability of CERT, and that's typically the case with a facility-based provider. And there's a lot of facility-based providers that don't fit those categories I mentioned in the automatic. Ambulatory surgical center and hospital-based. It doesn't apply at all to extended care facilities. But still, they share that same characteristic that in an extended care facility don't have control of the CERT. And then if there's extreme and uncontrollable circumstances, and that has a wide applicability, there have been fires, there have been floods, there have been significant illness or death in key members of the practice. There's a number of things that are uncontrollable circumstances that can qualify for an exception annually. One possible area for confusion I've found as I've been reading through the available data on special statuses available to APM entities, there's a note that says small practice is the only status available to APM entities, the only special status available. So I think because there's a little room for confusion of what that means, so both users, MIPS and APM participants may have some confusion, and even at the basic level, the help desk level at CMS, you may find some confusion. So it would appear to reconcile all the statements in the rules and in the federal list of rules, an APM entity is not permitted to apply for exceptions. So none of those application-based exceptions apply. And all of those, that list of exceptions I gave you earlier, can't apply to the APM except by the small practice exception. So I think watch that carefully, and if you get a misinterpretation in your scoring, be prepared to contest that when the scores are out.
So let me just make sure I understand. So for 2024, at the APM level, the only special status that could apply is this small practice status.
Correct. That's at the APM level. Anything else can apply to individual practices or providers in the APM, or even all of them. But it's evaluated at the practice or provider level. It's not evaluated at the APM level.
I see. So if I'm an ACO and I have 5 TINs, let's say, that participate with me, and all of them have a status of being hospital-based, they wouldn't have to report PI. So there wouldn't be an expectation of PI at the APM level as well, right?
That is correct.
Let's talk a little bit about what this is going to look like in 2025. We know that in the 24 final rule, CMS laid some groundwork for what they expect to be required for ACOs around PI reporting in 2025. What are you seeing with the 25 requirements, and how do you think this will impact ACO practices?
Well, the new rules were actually adopted with the 2024 final rule to go into effect for the 2025 performance year and beyond. So the changes as they're listed, and of course they can go back the other way with a new rulemaking, but this is what we expect here in 2024 as we're looking forward to entering the 2025 performance year. So the first change is that everyone in each APM, that's MIPS APMs and advanced APMs, needs to use CERT. There's a 100% requirement now. It's gone up from 50% in the in MIPS APMs, and it's gone up from 75% in advanced APMs. Now, those numbers are still in use in the 2024 performance year, but as of the 2025 performance year, it's 100% expectation. Also, all of those providers need to submit a MIPS PI category, make a MIPS PI category submission. And I expect Medicare is probably going to use that in part to assure compliance with 100%. Now, the usual exceptions apply to both of those issues, both to using, there are some exceptions that you don't have to have 100% of users using CERT, and not 100% of users need to submit. And the same exceptions that have always applied at the individual or group level to making a PI submission will apply to the collectively to each of those participants in the APM. And also, an APM entity is not permitted to apply for an exception. So if there's exceptions to be applied to any of those exception categories that are acceptable for PI, those applications need to be made from an individual or a TIN group level.
So in 2025, whether you are a MIPS APM or an advanced APM, whether you are MIPS eligible or a QP or a partial QP, everyone has to use CERT unless they're otherwise exempted, and everyone has to report PI unless they're otherwise exempted.
You nailed it. That's exactly correct.
Great. If TINs and NPIs can report the PI category on their own, why would the APM want to report it for them or be concerned about how practices or providers are reporting PI?
Well, I think the APM is going to have a very big stake in this. Medicare is not explicit about what will happen for noncompliance with this requirement, but I think that implicit implicit in all contracts for MIPS or advanced APMs is what happens when you break that contract. And I think you can expect at the very least to get a stern warning and a requirement for a remediation plan. And at worst, by being non-compliant with your contract, they may withhold any shared savings you may have earned.
So, Dr. Mingle, what should folks consider when they're deciding whether to report PI at the provider level, the TIN level, or at the APM level?
Oh, good question. Very good question. I think the APM has a big stake in this. Again, I think failure to have a valid submission applicable to each of the participants can affect your ability to collect on your shared savings. So there's a big role there to play. And I think I think APMs making a submission is a great idea, just to take control of it and make sure you don't have individual providers or small practices, participants neglecting this and affecting the whole group. Now, and there's this is yet to be shown with time with how Medicare handles it, but there's an advantage when you move from an individual submission to a group submission. Some of the measures that are attestation based or that require just one numerator instance to pass, the whole group takes on that. So if you have only one who's made that connection between patient and EHR, that has one that's complying with the referral-based interoperability, that can apply to a larger group. So I think there's that advantage that you gained for the whole APM. Now, the downside for the individuals, for the practices and groups, people are doing a great job and would get a higher score alone or as a group, may get a lower score as an APM, but there's no reason you can't do both. And we have increasingly people submitting quality submissions that will do an individual submission or when the group is not getting as good a score as they would be getting. So rather than accepting the group score, they make an individual submission to get a bigger MIPS, a better MIPS adjustment. So that can happen here in the APM PI level as well. Now for your advanced APMs, there's no other advantage of getting a PI score. It doesn't go into any kind of an adjustment if you're a qualified participant. But if you're a partial QP electing to participate in MIPS, or a MIPS APM who you're all participating in MIPS, it can make a difference in your adjustment if you accept the APM level score or make your own individual group submission.
I see. So there are really two things to consider, it sounds like. Everyone should be concerned about satisfying the shared savings requirements.
Correct.
And your non-QPs, meaning your MIPS APM folks or MIPS eligible providers, might see a negative adjustment if they don't successfully earn those points in the PI category.
Correct. And of course, remember that the danger is always there for a negative adjustment. So putting your own better PI submission in might earn you a smaller negative adjustment, or perhaps move you into the positive range. So you have to think about the whole range as you're thinking about that potential for the year.
Yeah, that makes a lot of sense. As you mentioned, I know a lot of providers might choose to make an individual submission in the quality, PI, and IA categories because their own score would be better than that of the group. It sounds like that might be a good strategy for providers or TINs to think about if they think their own score would be more successful than the score that would be achieved at the MIPS APM level.
I think you've nailed it, Brigid. So Brigid, thanks for all the great questions. That all gives me a question I have for you. You're prominent in our group of consultants who helps our clients navigate the quality payment program. How are you finding yourself and your group helpful to our clients in this PI realm with ACOs?
As I think we might have explored a little bit, PI is a category where there are lots of nuances and lots of exceptions based on really specific details. So everything you and I have talked about today is data information that's available through the QPP website, which is qpp.cms.gov. They have an extensive library of documentation and information. The really helpful part of that is that it's all the information any circumstance could need regarding reporting PI as an ACO. Where Mingle Health and our consultants really shine is we understand all of that, and we can talk about how it applies to your specific situation. As we mentioned, there are exclusions and exceptions and caveats. And so when you're meeting with a consultant, one of the first things we do is understand what's happening at your practice or at your ACO. And then we're able to explain how all of this information, all of these regulations and requirements apply in your circumstance.
Thanks, Brigid. It sounds like you're a big help to our clients, and I appreciate it. And thanks for all the great questions. And thanks to all of you tuning in. We love to hear from you. We love to hear your questions. If you found an issue with anything we said, we'd like to hear your corrections, your clarifications. So don't hesitate to be in touch. We love to hear from you. We can be smarter together.